my name is Hannah McMills. Today I'm going to be discussing feline injection site sarcomas, abbreviation FISS, with you. If you take a look at my slide right here, this is a brief overview of what I will be covering. Go ahead and pause to take a look. So first and foremost, what is FISS? So what are now known as feline injection site sarcomas were previously known as vaccine-associated sarcomas, or VAS. These sarcomas were originally thought to only be caused by vaccinations, but have been found to be caused by many other types of injections, including vaccinations, antibiotics, steroids, non-absorbable suture materials, and microchips. While I will cover the histotypes later in the presentation, an FISS is a mesenchymal neoplasia of aggressive behavior. It is highly invasive and can metastasize. They can rapidly recur following excision, and necrosis and ulceration are common. So a brief historical overview. FISS, then VAS, began to be recognized in the late 1980s when an increase in fibrosarcomas was noticed by the University of Pennsylvania's School of Vet Medicine. This increase coincided with the introduction of feline leukemia and rabies vaccinations, as well as a 1987 Pennsylvania law that required a rabies vaccination in cats. In 1991, the first warning was made to the general veterinary profession, and it reviewed the increase of sarcomas at the vaccination sites. In the letter, practitioners were encouraged to keep records regarding date and anatomical location of the vaccine administration and submit masses for histological examination. In November of 1996, the Vaccine-Associated Feline Sarcoma Task Force was formed in the United States to investigate the epidemiology, treatment, and prevention of these malignancies, as well as to disseminate information to vets and the cat-owning public. They also published vaccination guidelines and a guide to diagnosis for FISS. So the epidemiology of FISS. So for incidence, statistics can vary. They vary from 1 case per every 10,000 vaccines to 1.3 cases per 1,000 vaccines. There are around 300 to 500 cases per year in Canada, around 2,000 cases per year in the United States, and they comprise 13% of all examined skin tumors in cats. The low incidence can be explained by multifactorial etiology, as well as the fact that different cats may have different genetic predispositions to develop FISS. So the target group, FISS is not restricted by age, and there is no sex predilection. The interval between injection and development of a tumor is variable from 1 month to 3.5 years or more. There is an increased risk of FISS with the increased number of injections given simultaneously at the same site. So the risk was 127% when 2 vaccines were administered, and up to 175% when 3 or 4 concurrent vaccinations were given at the same site at the same time. So there is still a high recurrence even after surgery, and then metastasis can occur in up to 27% of cases. The most common reported sites are regional lymph nodes and lungs. FISS is more likely to become metastatic than non-injection site sarcomas. So what are the histotypes? There are 10 histopathological features. Presence of 7 of these features classifies it as an FISS. They're all listed here for you. Histopathological assessment. So most often FISS are often fibrosarcomas, but they include many other types of sarcomas listed here, such as chondrosarcomas, myofibroblastic sarcomas, and malignant fibrous histocytomas. Pictured here on the left, there's an inflammatory response in the peripheral part of the tumor, and then zoomed in a little bit more on the right-hand picture, there is a multinucleated giant cell you can see right there. So what is the pathogenesis of FISS? So there is no link to specific vaccines. The sarcoma rate is not influenced by the brand of vaccine or type of vaccine, and there is no viral component in the pathogenesis of FISS. So the predominating theory at the moment is that persistent inflammation or wound healing associated with the vaccine components or injection components leads to the proliferation of fibroblasts and myofibroblasts that undergo neoplastic transformation. So the idea is that FISS develops from proliferating fibroblasts and myofibroblasts at the site of the chronic inflammation. The cytokines are involved in the promotion of malignant transformation by the stimulation of division and migration of vascular endothelial cells, and by activating DNA synthesis and mesenchymal cells. So a chronic inflammatory stimulation can elicit proliferation of fibroblasts through multiple cytokines and growth factors, in addition to overexpression or mutation of oncogenes and tumor suppressor genes. 2 things that have been found that have been linked to FISS include overexpression of platelet-derived growth factors, or PDGF. These stimulate fibroblast proliferation and play a role in tumor genesis. Overexpression of PDGF and its receptor can lead to neoplasia, and they have been exhibited in feline sarcomas. Now for P53, cats with cytoplasmic expression of P53 had a shorter time to local tumor recurrence. Abnormal expression of P53 has been found to be a common feature in FISS, and mutations in P53 were identified in surrounding histological normal tissue up to 5 centimeters distant from the tumor. So P53 is a common factor in FISS. Overall, FISS can arise at the site of injection administration as a result of chronic inflammation. This suggests that some cats may have a genetic predisposition to injection site-related sarcomas. So how do you diagnose an FISS? So you use the 3-2-1 rule to decide whether to biopsy a lump in the injection site of a cat. They must be characterized by at least one of the following: present in any form 3 months after a vaccination is given, greater than or equal to 2 centimeters across at presentation, or present for 1 month after vaccination and fast growing. As you can see in this picture, this particular cat does have a pretty big mass on his lower neck area. Treatment. So the most effective treatment combines radical surgery with pre or postoperative radiotherapy. Chemotherapy can be used as a palliative method of treatment, but it is considered an adjunctive therapy, not the be-all end-all. It's important to use advanced imaging to determine the extent of the surgery and or the size of the radiation field. So specifically for surgery, this will require radical surgery or a wide excision surgery with 3 to 5 centimeter margins. Anything less than 3 to 5 centimeters is more likely to recur than just a 3 to 5 centimeter margin. Radical surgery can also include amputation if deemed necessary. It all depends on size, localization, and general condition of the cat. However, no matter the surgery, there is a recurrence rate of 70% or less, so still pretty high. The disease-free survival time after any surgery is only approximately 6 months because of the recurrence rate. So prevention, how can we prevent FISS? Well, this all has to do with injection recommendations given to veterinarians. So a 2005 vaccination policy by VAF-STF said to vaccinate the largest possible number of individuals in the population at risk, to vaccinate each individual no more frequently than necessary, and vaccinate only against infectious agents to which individuals have a realistic risk of exposure and subsequent development of the disease. So for instance, I work in a veterinarian's office. I am a vet tech. One of the things we will ask before we do a feline leukemia injection is, are they around other cats? Do they go outside? If the answer is no, and it's just an indoor cat, it's not as likely to be subject to feline leukemia, so we may or may not need to vaccinate for that particular disease. Other vaccination guidelines include that no vaccinations should be given in the intrascapular space, only subcutaneously. Subcutaneously means between the skin and the muscle, so that little space in between is where we vaccinate. There are specific locations for specific vaccinations based on the guidelines we are given. So feline leukemia can only be given in the left hind limb as distal as possible. Rabies will be given in the right hind limb as distal as possible. And then FBRCP and other vaccinations are done in the right shoulder. All vaccinations are done as distal as possible, meaning that they are situated away from the center of the body or from the point of attachment. You want to get as low as you can on the leg. That is just because in the case that an FISS does occur, and we do have to amputate the leg, you don't have to amputate as far up as if you would have done it, higher up. The reason this applies to me and why this interests me, I am a vet tech. I actually was just accepted into vet school, so I will be a future veterinarian. As you can see here, I am with one of our cats at our local hospital, and then these on the right are my fur babies. So this is a topic that is very close to my heart and something that I can relate to. So I hope you enjoyed my presentation. Here are all my references. I hope you learned something from this. I know it's a lot of information, but I'm really passionate about it and enjoy learning. So I hope you enjoyed it. Thank you.